Hey everyone, I hope you're doing well. Today we're going to be talking about vasculitides, which I recently learned is the plural form for vasculitis. So what is vasculitis? It's not an immune condition, it's a group of conditions characterized by inflammation of the blood vessel or vascular. Makes sense. Why is that important? Well, it's because inflammation is often going to lead to associated damage and ischemia of the vessels themselves, and therefore the organs or the parts of the body supplied by them. We usually classify them based on the size of the vessels that are usually affected. So you have large vessel, medium vessel, and small vessel vasculitides. And I think when we talk about the diseases, try to think of what each of these vessels we talk about supply and how inflammation or damage to these vessels is going to present clinically. Let's start with large vessel vasculitis. There are two main ones we'll be talking about, Takayasu arteritis and temporal arteritis or giant cell arteritis. The first one, Takayasu or aortic arch syndrome, is basically, as the name suggests, inflammation and thickening and then subsequent stenosis of the aortic arch and its branches. So it's more common in women, and that's a trend that's seen in almost all vasculitides. In terms of general features, and this is something that's going to be very common across the board, fever, malaise, arthralgia are going to be quite common features of almost all vasculitides. And then as I said, try to think of vessel-specific features. So you're going to have decreased brachial and radial pulses because you have stenosis of the aortic arch. You can have syncope and angina because you have the branches being affected, and you can also have carotid bruits based on that stenosis. Diagnosis is based on lab findings with an increased ESR. And we talk about ESR over CRP because CRP is usually an acute phase marker and often isn't a good reflection of these chronic autoimmune conditions, and ESR tends to do a better job with that. The gold standard imaging of choice is angiography, as you can see on the right here. The arch itself looks decent. However, as you can see with the branches, you have these areas of stenosis throughout, and it just looks wrong. It doesn't look like a nice confluent vessel. In terms of biopsy, you would see granulomatous, Jesus Christ, granulomatous thickening of the arch and plasma cell infiltration because it is a plasma cell driven or an antibody driven process. In terms of treatment, well, you want corticosteroids to reduce the inflammation, antihypertensives to reduce the blood pressure, which is going to be associated with the aortic arch stenosis. And you can often have surgery if the vessels are critically stenosed. So often you could do a carotid bypass. These are going to be, like this page itself, if you take this in, it's going to be applicable to almost all the diseases we talk about. So general features are almost going to be the same. You then have the vessel-specific stuff, which you can figure out. Diagnosis is most commonly going to be with an elevated ESR, and then some form of biopsy is going to show some chronic thickening with plasma cell infiltration, because the underlying process, which is an autoimmune B-cell mediated process, is going to be quite similar across the board. Second, we have temporal arteritis or giant cell arteritis. So again, it's inflammation, thickening, and stenosis, particularly of the carotid and its branches. Now, instead of the aortic and its branches, it's carotid and its branches. Again, more common in women and almost always seen in elderly, well, not elderly, patients above 50. There's also a very strong association with PMR or polymyalgia rheumatica, which is the disease we talked about earlier, characterized by stiffening of the shoulders and the hips particularly. General features, again, are the exact same. So fever, malaise, arthralgia, but now we have vessel-specific stuff. Now, when you talk about GCA, I'm sure you've heard of some symptoms, but if you think of the vessels and how they kind of work, everything kind of just makes a lot of sense. So you often have new onset unilateral headaches, particularly over the temple area. And that is because there's inflammation of the temporal artery, which is here. You can have jaw claudication because the lingual or the facial branch is being affected. Scalp tenderness if the frontal or the occipital artery is affected. You can have amaurosis fugax, which is this really bad medical emergency of a complication where you have now got inflammation and stenosis of the ophthalmic artery, and that's going to present with just darkening, and it's typically characterized as the curtain falling over your vision. It is a medical emergency. It's seen in 15% of cases, and you need to be really cautious, because if they had it in one eye, more likely than not, they're going to have it in the other eye too. So you want to manage them very aggressively. As I said again, diagnosis is based on a high ESR. You have some form of a gold standard investigation. For this, it is a temporal artery biopsy, but this has its drawbacks. Firstly, you want to be able to do it immediately, especially if you have any of the bad complications, like if you have amaurosis, fugax, visual changes, all of those warrant immediate temporal artery biopsy. So firstly, having to do it can often be challenging. You need a 1.5 to 2 centimeter segment, or many of them, because temporal arteritis doesn't present with continuous lesions. As I said, it can present in any of those arteries, and you could have a very possible chance where either the lesions are patchy or they are not affecting that vessel altogether. So if someone comes in and their primary complaint is jaw claudication and amaurosis fugax, and you do a temporal artery biopsy, odds are you could potentially have a false negative. Again, you would see mononuclear infiltration of the vessel. All that means is that it's a one type of cell that's infiltrating. It's most commonly going to be, again, a B cell mediated process, and you're going to have giant cell formations within the vessel wall, which is why it's called giant cell arteritis. You can also do imaging. You can do a duplex ultrasound to look at the flow within the vessel to identify signs of inflammation and stenosis. And apparently, new studies have shown that if done by a trained clinician, it is almost at par in terms of its diagnostic probability as a temporal artery biopsy. So they're pretty good if done well. In terms of treatments, corticosteroids would be the go-to choice. If you have a very high index of suspicion, you would go immediately starting them on steroids. If there's visual loss, you want to start them on pulse methylprednisolone, or methylpred, which is 1 gram a day for 3 days. You want to go really strong with this, because the odds are they might lose their vision altogether. If they have no visual loss, you can go just the oral pred route, and that's going to be 40 milligrams for 2 weeks, and then you change the dose with a total course of 6 to 12 months. That is a long course, and almost all people, if put on a high steroid dose for that long, are going to develop some of the steroid side effects. So you need to be very mindful of those side effects when you do start someone on long-term steroids. Tocilizumab is a monoclonal antibody that's been shown to be very useful when started alongside steroids. And often what they usually do now is, instead of 1 full year of steroids, they hit them with a 6-month steroid plus tocilizumab combo, and that usually has been shown to have a better response. Now, you don't need to know any of what I've just said from a treatment perspective. All you need to know is steroids. If visual loss, IV steroids. If no visual loss, oral steroids are fine. The dosing is not important and will never come up. Next, talking about medium vessel vasculitis. The first one is Kawasaki disease. Now, you'll cover this extensively next year when you go through your pediatric rotation. It commonly affects children under the age of 5 and is more common amongst people of an Asian background. The characteristics are, so these are 5 features that are almost always, well, not almost always, but are very typical of Kawasaki. So a very high fever, and I'm talking 39s, 40s. You often have a desquamative rash and erythema of the palms and the soles, so hands and the feet. And desquamating just means that the skin's often peeling off as well, which you can see here. They can have conjunctivitis, mucositis, and often have cervical lymphadenopathy. And it tends to be like pretty enlarged. The diagnosis is most commonly clinical. So if you see these features, they have Kawasaki. In terms of treatment, you can start them on IV immunoglobulins. and high-dose aspirin. The reason we start them on high-dose aspirin is because of one of the rare complications of Kawasaki, which is an aneurysm of the coronary artery. And that's why we start them on aspirin. And you often do a follow-up echo, usually 6 weeks after their time of diagnosis, to monitor and look for those coronary artery aneurysms. Next, we have polyarthritis nodosa, or PAN. So it commonly involves the vessels supplying the skin, muscles, joints, and kidneys, and it is a very strong association with Hep B. Now, again, the general features are the exact same: fever, malaise, arthralgia. And you could say this for all of what we've talked about today. The vessel-specific features, again, I said it really makes things easier if you go back to the vessels being supplied to the organs being supplied by the vessels and work your way backwards. So, as I said, if they have renal involvement, CKD and hypertension, skin involvement, rash and nodules, why it's called polyarthritis nodosa, because of the nodules. With GI, they can have abdominal pain and melena, if you think of kind of an ischemic process. And it usually spares the lungs. I don't know why I added that in, to be honest. It usually spares the lungs. Okay, I'm not sure why I added that bit, but there you go. It usually spares the lungs. And a diagnosis is based on angiography and a muscle biopsy because it affects the muscles quite commonly. Now, when we say doing a muscle biopsy, we don't actually see infiltration or any autoimmune process in the muscle. What we do see is atrophy of the muscle and ischemic change to the muscle because the vessel supplying it has gone ischemic. I hope that makes sense, right? Because usually when we do biopsies, we look at the part that's affected directly. So, if the vessel's affected, we biopsy the vessel. Here we are biopsying what the vessel supplies. Why? Because, well, it's harder to biopsy tiny vessels supplying the muscle. Considering it's a medium vessel vasculitis, that's going to be harder to do. And also, muscle and skeletal muscle usually should not be ischemic unless you have something like rhabdomyolysis. But in the absence of rhabdo, you shouldn't have ischemic skeletal muscle. So if you do have, it's quite suggestive of PAN in the context of general and vessel-specific features. The treatment is, again, immunosuppression with steroids and cyclophosphamide. Next, we have thromboangiitis obliterans, or Buerger's disease. Now, it affects veins and arteries of the upper and lower limbs and very commonly presents with peripheral vascular disease-like symptoms, right? So it presents very similarly. So again, they have that intermittent claudication, they might have Raynaud's phenomenon, but it's different to PVD because unlike PVD, this is not atherosclerotic. Peripheral vascular disease is when they've had cholesterol buildup over the years, it's thickened, it's stenotic. This is different. This is an autoimmune process driving a similar inflammatory and stenotic process. The general features are the same. Also to note, it is very highly associated with smoking. Vessel-specific features, so intermittent claudication, Raynaud's phenomenon, and a migratory thrombophlebitis. So thrombophlebitis is inflammation of the blood vessels and the veins, and it's often migratory in terms of it can be one place somewhere and then move alongside, which is not seen in many other things. So the diagnosis is based on you can do a Doppler ultrasound and arteriography, and that's going to show the areas of stenosis. And you can also do something called an ABI, an ankle brachial index, basically measuring the blood pressure difference between the ankle or the arteries in the ankle and your upper arm. And it's quite similar to what we do with peripheral vascular disease. Even with PVD, you would have a reduced ankle brachial reflex. But if you don't have a florid metabolic history and have most of this autoimmune sounding general malaise looking disease process, then it's a higher suspicion for Buerger's. I also don't know why it's called Buerger, probably named after someone. The treatment is firstly smoking cessation, protection of fingers and toes because they are at a higher risk of frostbite and whatnot. You can use iloprost, which is a prostacyclin, which can open up those blood vessels. Calcium channel blockers, especially peripheral acting calcium channel blockers, like the pines. So nifedipine, amlodipine are all good because they cause peripheral vasodilatation. And then you can often have to do revascularization if there's critical stenosis. Finally, with small vessel vasculitis, we brought them into two categories, the ones associated with ANCA and the ones that are not associated with ANCA. As you know, ANCA is the antibody marker we commonly use. And within ANCA, you have these three conditions, and I hate the names of all three of them. So firstly, you have granulomatosis with polyangiitis, and it was previously called Wegener's. So Wegener's ANCA. And then you have eosinophilic granulomatosis with polyangiitis, previously called Churg-Strauss vasculitis, or Churg-Strauss polyangiitis. So there's Wegener's polyangiitis, Churg-Strauss polyangiitis, and then microscopic polyangiitis. Polyangiitis just means that there are multiple small vessels being affected, and so it's a inflammatory process affecting many of the small arteries. And then you have non-ANCA associated small vessel vasculitis, so IgA and cryoglobulinemic vasculitis. The only difference being that ANCA is not positive. Now, what does ANCA stand for? So ANCA stands for anti-neutrophil cytoplasmic antibody. All that means is there an antibody to something within your cytoplasmic, within the cytoplasm of your neutrophils? And that we've already gone through antibodies, so I don't want to talk much about them. But just know that, yeah, the first three would have a positive ANCA, which can be either P ANCA or a C ANCA, depending on which subtype it is. But we'll talk about that in a quick. Nice, we'll talk about it now. So which ANCA is affected? So C ANCA is affected in. I'm just gonna call them Wegener and Churg-Strauss because I don't like saying this entire thing. The reason it's not called that anymore is because Wegener was a Nazi scientist, and we don't want to be naming the diseases after Nazis, which is why it's not called granulomatosis with polyangiitis. I'm not sure whether Churg-Strauss was also a Nazi, but I feel like with one being changed, he decided to change both. It's a bit of a rip for Churg if that wasn't the case, but anyway, sorry, getting back to it. Before we go through this table, just a good memory tip for granulomatosis with polyangiitis. It's called C disease. So it has all of the C stuff. It has a curvy nose. Okay, wait, we'll go through this first. Sorry. Okay, so what is affected with granulomatosis with polyangiitis? So you get chronic sinusitis and often a saddle nose deformity. So the nose just looks saddle-like. It's different to like the bulging nose. And it's often associated with ischemic damage to the underlying cartilage, which is why you get a saddle-shaped deformity. And you often have a rapidly progressing GN. Other things of relevance, P ANCA is eosinophilic granulomatosis. You also often get multiple lung nodules on a chest X-ray with the simple one, and you have an elevated IgE, which makes sense because it's an eosinophilic process. With microscopic polyangiitis, you see this thing called a pauci-immune glomerulonephritis. Now, what does pauci-immune even mean? Pauci-immune means it's like a fake immune. Why is it a fake immune? Well, if you take a biopsy of a kidney, or in someone who has this condition, you often would see the deposition of a lot of antibody processes. And then the question is, well, isn't that a real immune glomerulonephritis? Well, not really, because the antibodies weren't to the kidney itself. It's antibodies created elsewhere, like in the small vessels, that have now gone and just gotten stuck into the glomeruli, which is why it's called a pauci-immune process. The treatment for all of them is the exact same. So glucocorticosteroids plus methotrexate or cyclophosphamide or rituximab. You don't need to know the specifics, just know that steroids are good enough. Now, just know that granulomatosis with polyangiitis is C disease. So you have the curvy nose with the saddle-shaped deformity, you have the chronic sinusitis, the cough, the C-ANCA, conjunctivitis, the non-caseating granuloma. And now this is a bit of a far-fetched one because you're going to think caseating, but it's non-caseating, treated with corticosteroids, cyclophosphamide, and it was also called Wegener's, and Wegener was a... Anyway, speaking of non-ANCA vasculitis, we have IgA and we have cryoglobulinemic vasculitis. So IgA vasculitis, again, you'll be covering this extensively next year in peds, commonly seen in kids, associated with palpable purpura of the lower limbs, again, with those common features like arthralgia, also associated with abdo pain. You will have increased levels of IgA in the serum. That's why it's called IgA vasculitis. And often you can also have IgA nephropathy, which is one of the leading types of nephritic syndromes. You then have cryoglobulinemic vasculitis. Now, I don't know much about this. I don't think you need to know much about this. Just know that cryoglobulins are not good. And if they get into the vessels, or if you have too much of this in your body, you're going to end up with a cryoglobulinemic vasculitis, where the cryoglobulins cause inflammation of the vessel lining. It is also associated with palpable purpura, fatigue, and glomerulonephritis, highly linked to hepatitis C. I don't know why that happens, but it happens, and you may choose to know it if you'd like. And that is all I had for today. Thank you, everyone, for your time again. As always, if you have any questions, please feel free to get in touch. And yeah, I hope you're enjoying your year so far. Definitely an exciting time. So just please make sure to take it at a time and don't overwork yourself.